Hello, I'm Dr. Zayd Alhaddad from the William Harvey Hospital, currently doing my F1 year. I'm going to talk to you about heart failure. It can be a difficult topic, but I'm going to break it down for you so you understand it quite easily in both the diagnosis and the management. So first, what is heart failure? Heart failure is basically the inability of the heart to pump properly. So heart can't pump blood forward into the body properly. And there are different types of heart failure. So there are two categories, side and cause. So sides, right-sided or left-sided, or it could be both. And sometimes one side can lead to dysfunction of the other side. But it's important to know which side is causing the problem, because that can help you diagnose and it can help you treat. And then also it can either be systolic, which is also known as heart failure with reduced ejection fraction, or diastolic, which is heart failure with preserved ejection fraction. So let's talk about systolic heart failure, HFrEF. So the heart is failing to pump blood forward, and this is a failure within the pump itself. It fills fine. It can be caused by different things. Three main categories: leaky valves, so any valvular regurgitation. Let's say you have mitral regurgitation, for instance. The heart's pumping blood forward, but not all of it is going forward. Some of it is going back into the left atrium, hence it's not going in the right direction. It's a systolic issue. Also, dead myocardium. So that's ischemia, infarction. If you have your MI, you're going to have part of your heart walls that are damaged. You're not going to be able to pump properly. Or dilated cardiomyopathy. And that can be caused by alcohol, by medications. It can be caused by hypertension. And this is when the heart itself, the ventricle dilates, and it's not as good as pumping blood forward. Hypertension is the most common cause, and that's because the heart is so used to pumping out blood against high systemic resistance, and that tires out the heart over time. Now let's look into diastolic heart failure, HFpEF, and it's failure of the heart to fill properly. So if blood can't get into the heart can't pump it out. And it's caused by, again, three different main categories: pericardial problems, so that's like your pericardial effusions, your tamponades, or your constrictive pericarditis. There's also cardiomyopathy, so that's your hypertrophic or your restrictive cardiomyopathy, and that's going to cause so basically the heart walls are either too thick and there's not enough space for blood to fill the ventricles, or it's restrictive in the sense that it's just very hard to move. It's very solid and it just can't accommodate blood entering. And then your deposition diseases, which is amyloidosis, which is important to look out for, especially in a patient who comes in with heart failure and renal failure. So what are they going to come in with? Your signs and your symptoms. So fluid is going to fill up before the pump, and this is important to know when it's right-sided or left-sided, because where the pump is the heart, and if it's a right-sided failure, you're going to get fluid buildup in the systemic circulation, because it's what comes before the right side of the heart, your IVC. So that's going to be where the fluid's going to build up. So you're going to get your peripheral edema. So, swollen extremities, you're going to get mainly your feet, your ankles. Depending on how bad it is, it can go all the way up to the abdomen. So always look out for that. Feel where the edema stops. You can also get your hepatomegaly, because blood can't get back into the right side of the heart. Left-sided, it's going to the fluid is going to build up in the lungs. So you're going to get your pulmonary edema. You're going to get short of breath. You're going to get paroxysmal nocturnal dyspnea. And overall, what you're going to have is patients who are going to come in. They're going to get decreased perfusion. They're going to get fatigue, lethargy, exertional dyspnea. Just basically that's the main complaint they're going to have about the heart failure itself. Of course, they can have symptoms of the causes, and then in signs when you're looking, you can also see maybe a raised JVP, third heart sound, and these are prognostically bad if a patient comes in with a raised JVP and a third heart sound. So workup, what are you going to do for a patient who comes in with heart failure? Of course, first of all, you're going to take a very good history and examination. Look for the causes in your history, past medical history. Do they have a history of MI? Do they have any of the other causes that might have caused this, and then examine them, look exactly how bad the extent is. Let's try to find if there's another cause for heart failure, including lung pathology. And then your first blood test, usually done in the community and in hospital, not so much because we skip to the next step, but your pro-BNP, which is released from heart cells when there's too much fluid, which causes the cells to expand, releasing the pro-BNP. So it's a very easy way to see, does this person have heart failure? If it's elevated, then they probably have heart failure. If it's low, then they probably don't. And then the most important step is your echocardiogram. So the echocardiogram is important because it tells you how bad it is, and also it helps you differentiate between systolic and diastolic. So systolic will have an ejection fraction of lower than 55%, while diastolic will have a normal ejection fraction. You can also see parts of the causes. So is there a focal area of the myocardium that is just akinetic? Is there significant valvular disease? Echocardiogram is the most important step in A, diagnosing, and B, following up patients. When they come into hospital with an exacerbation, which we'll talk about later, the echocardiogram is important. And then we also want to do our other tests. And it helps us determine the cause and also the extent of the damage. So you want to see your chest x-rays, you want to see your ECGs, your bloods, your urinalysis, and your spirometry. All of these will help give you clues about why this patient has heart failure and potentially also how bad the heart failure is. Now let's talk about management. So you always want to consider addressing the cause itself. And then why is this patient in heart failure? Is it ischemic? Is it valvular? Potentially there's something you could do about that. You also want to refer to a specialist. Most hospitals will either have a heart failure specialist nurse, or you can go straight to the cardiology team. They will be very helpful in helping tweak the medications and carrying forward management in the community after a patient is discharged from hospital. And then every patient you see, you're going to want to give them lifestyle changes. Tell them to quit smoking if it's associated with heart failure, and it will help destroy your heart if you continue to smoke. So tell them to stop smoking. It's the most important thing. Also, you want to fluid restrict them to 2 liters a day. Changes depending on the patient themselves. Sometimes in hospital you have it lower, and remember, that includes anything they eat, anything they drink, anything you give them IV. And when you give them IV, it's not just the fluids themselves, but remember, if you're giving them antibiotics, that also comes with some fluid to dilute it. You want to keep track of that, so keep fluid charts, ins and outs, keep that religiously. Daily weights in hospital are also very helpful because that's a bit more accurate. And then salt restriction. Differing evidence on this, but generally overall, if they can remove from their diet, that's always helpful. Then when it comes to the medical management, first thing, everybody who you see who has heart failure, you're going to start them on an ACE inhibitor, and if they can't tolerate that, an angiotensin receptor blocker. And then you also want to start them on a beta blocker. These 2 medication groups are the most important when it helps with prognosis and their survivability in the long term. After that, you can start adding diuretics if they're still symptomatic. That's just going to help them get the fluid overload off. Doesn't really help with the prognosis, but it's very helpful for patients. You can also add spironolactone, eplerenone, so these are mineralocorticoid receptor antagonists. These will also help with the prognosis, but these are given at a later stage. You can also give them hydralazine or azosorbide dinitrate. You can check the nice guidance on when it's best to give each one, but this is just a general overview. By this point, you'll hopefully have your heart failure specialist nurse or your cardiologist involved. And then at the 4th stage, inotropes, dobutamine. This is when their heart is really not doing so well. So you're going to want to give them dobutamine to help keep the heart pumping properly. Mechanical devices, LVADs, so that's a left ventricular assist device. It's only a short-term measurement to help to get to the transplant stage, but sometimes they might need that. And then also they might need ICD because their heart can stop, it can go into arrhythmias which an ICD can help put them back into a normal heart rhythm. So let's talk about your acute exacerbations. So, most importantly, full workup. You want to find the cause. Why are they in acute exacerbation? Why did this patient come to my hospital instead of staying at home today? Well, he has symptoms, and that's going to be caused by something. Is it an infection? Have they gone into AFib? There are a lot of different causes, so you want to do a full workup and find out what it is. And then to treat the heart failure itself, very easy. Remember, LMNOP. Lasix, which is the brand name for furosemide, help get that fluid out. Remember the fluid restriction, and then you give them Lasix to get it out. Now there's a fine balance in the real world between giving them Lasix and causing AKI, and it's really kind of, you got to play around a little bit, but you'll have senior input at this stage, and this is when the cardiologist might have to get involved if things get a bit dire. Morphine, it helps with the pain, it helps with the breathing. Nitrates, you want to decrease the systemic resistance, decrease the pressure, it helps put ease on the heart. Oxygen, give all your patients who are acutely unwell oxygen, especially when there's a problem with the perfusion. The more oxygen they have, the more they can get away with having less perfusion. And then positioning, put them upright, which will help them breathe. And then remember, treat the cause. If it's an infection, you want to treat the infection. If it's AFib, treat the AFib. Rate control, rhythm control. And then finally, for a quick summary, important things to know: right disease versus left disease, systolic versus diastolic, your echocardiogram, which is the most important test when it comes to heart failure, both in diagnosing and following up. Especially in the acute exacerbation, you want to get that echocardiogram. Remember to escalate early to the proper avenues, being at the heart failure specialist nurse or the cardiology team. Remember, everybody you see in the front door, you're going to give them an ACE inhibitor and a beta blocker unless contraindicated, because those are the two most important drugs for prolonging life. And then remember your acute management, LMNOP. And that's heart failure. If you need more help, more information, you could go to the nice guidance just to have a deeper view of exactly when to use which drugs. And remember, get out there. It's not too difficult once you break it down into the different parts, and good luck.